redo this. But anyway, ocular ultrasound. We're going to do a brief introduction today in the time that we have remaining to kind of get us, on a good foundation for ocular ultrasound. And then in subsequent weeks, we're going to talk about vitreoretinal disorders, the optic nerve, and some trauma issues that come up with the eyeball. So that's the plan. But as we get started here, I always like to frame things in the context of a case, right? Just to kind of set the stage, kind of get our minds engaged and thinking about it, so we can understand the material to come. So imagine yourself working in the department, and these are completely made up, right? Out of thin air, I just kind of made this up. But it's certainly plausible patient that we could roll down to the ED and potentially see this afternoon if they were to come in. So imagine yourself with a 52-year-old female presents with sudden painless vision loss. They come in and say, "Doc, I don't know what it is, but my left eye can't see out of it. This is very disconcerting for me." So as we think through this case, right, assuming the physical exam matches up with that, this kind of conjures up in our mind a differential of, like a vitreous hemorrhage or a retinal detachment, or even like a central retinal artery occlusion, or even like an occipital stroke. I mean, that should be the differential that, that we should kind of think through as we pursue this patient. And then secondly, if we have the next case, a 34-year-old dude, got into a pretty bad car wreck, has a bunch of facial injuries, and they have this this ginormous, beefy, black eye, right? This huge upper and lower right eyelid hematoma, and obviously decreased vision. But I don't know why is the vision decreased? Because they can't get their eye open. These are always hard to examine that eye underneath the big hematoma. So is it a lid hematoma? Do they have an 8-ball hyphema? I mean, that would certainly give you loss of vision after an incident like this. Traumatic lens dislocation would certainly do it. Vitreous hemorrhage, retinal detachment, choroidal detachment, ruptured globe, foreign body, retrobulbar hematoma. These are all differentials kind of this patient, of what we're going to need to work through. And so I think we can see that, basically besides, calling ophthalmology and having them figured out for us, we're going to need to kind of tease through this ourselves, right? And so here, at Metro, we are well-resourced. Ophthalmology is always a phone call away, and they're probably the happiest consultants we ever call. But imagine yourself out in a community hospital, or even at one of our satellites where ophthalmology isn't in-house, and you need to make the decision, transfer or not, to then go to the clinic tomorrow, or they need to come in to the big house. And I remember when I was teaching at Ohio ACEP a couple years ago, one of the students at our class, we were talking about ocular ultrasound. He's like, "Yeah, I have a real hard time with ophthalmology. Like, we have to call an ophthalmologist, 2 hours away to get permission to transport the patient to a hospital where they potentially see them." And so they were just bemoaning the difficulty it was to have ophthalmology involved in some of those cases. And so here's an example, these are situations where ocular ultrasound might come in handy. But the first thing that we're going to do, before we even get there, obviously, is do a detailed physical exam, because that's going to kind of lead us down, our ocular pathway and help us decide, if ultrasound or where ultrasound might play, and kind of narrow that differential. So if we go through kind of the American Academy of Ophthalmology detailed eye exam, right, it's going to include things like visual acuity. It's the vital sign of the eye. You're going to look at pupils, your extraocular movements and alignment, kind of making sure the muscles and the neuro component of the mechanics of the eye are working. Obviously IOP is going to be your next it's gonna be your next vital sign of the eye, and then looking at visual fields. How is the nerve working? And they want you to look at the eyeball itself, just that gross visual examination, and look under the slit lamp, kind of at the details, and then a fundoscopic exam. And all of that kind of factored together is that comprehensive, detailed eye exam. And certainly we're not going to be doing all of that for all of our patients, but that's kind of what would be involved if you're kind of being thorough. And as you narrow that down, right, the slit lamp exam is going to look at lids and lashes, the lacrimal system, conjunctiva sclera, cornea, anterior chamber, iris, lens, and the anterior vitreous, like these different components that we can actually see, as we look at the eye, grossly, as well as, as under the microscope. So looking to see, are there any, is there any inflammation, any laceration, any trauma to the lids and lashes? For the cornea, is it clear? Are there any disruptions to the epithelial layer? Any stromal opacities? Like, do they have a corneal abrasion? Do they have corneal ulceration? Is there any, complete through and through injury? The anterior chamber, is it deep or is it shallow? Is there cell and flare, things that suggest inflammation? For the iris, is it round? Is it tear shaped? Is there evidence that there may be an open globe or anything like that? From a lens standpoint, is it clear? Do they have any cataracts? Well, that's a little less of us thing. That's more of an ophthalmology thing. And then the anterior vitreous, is there signs of inflammation, hemorrhage, like a hyphema or anything to that effect? And this is really the kicker, right? This is where kind of all the fun happens in the eye, is on the fundoscopic exam, right? So all the pathology, there's a lot of anterior pathology, but all the interesting pathology tends to live in the back, although I'm sure my cornea colleagues would get very, very disquieted to hear that all the fun is in the retina. But basically in the fundoscopic portion, you're looking at the optic nerve, you're looking at the macula, the vessels and all the periphery, and are there any issues as it pertains to, the back of the eye, like that retinal area. And the hard part, right, is this is really hard to accomplish without, good equipment and without dilating the eye, and frankly, without lots of practice. If you talk to an ophthalmologist, they'll say, oh yeah, using the ophthalmoscope, it's like shooting fish in a barrel, well, I don't know, but I have a BB gun trying to shoot minnows in a very, very small barrel through a very, very small hole. And so it can be challenging kind of in the ED context. And so there's a couple different methods of evaluating the posterior portion of the eye, right? And if we just think big picture of what the tools are at our disposal, if you can CT them, right, you can MRI them, I would, posit to you that these are probably bad ideas if you're just purely trying to see the back of the eye, because it involves, transporting the patient out of the department, it involves radiation, it involves, in the context of an MRI, a very, very long study where you're putting, somebody through a very, very small tube and having them hold still. And so they're really not the best. OCT, optical coherence tomography, is a great view. Like it's a cross-sectional view of that posterior aspect of the eye. But again, it's not available to me in the ED. This is an ophthalmology specific thing. And so ultrasound really kind of rises to the top as one of these adjuncts to my exam to really help round out, no pun intended, the view of the back of the eye. Because it's been proven to be obviously portable. The whole idea of point of care ultrasound is portability. It's safe, it's reproducible, and it provides a lot of benefit and utility to our patients. So with that in mind, the outline that we're going to kind of hit at today for the next, 20 some odd minutes or so is basically looking at, when we do this, what do we need to know about machines and knobs? How do we perform the study? And then once we kind of figured out the mechanics of the machine, right? How do we do it actually on the patient? What do we need to do about when we roll up to the bedside and actually get this accomplished with that patient in the room? And then with that knowledge, we'll talk a little bit about ocular anatomy, just refresh our memory from medical school the last time we reviewed this, and then translate that to what we're going to see on the ultrasound screen. So that in weeks to come, when we start adding in pathology, then all of a sudden we can kind of start seeing what's abnormal about these different studies, right? So first and foremost, machines and knobology, right? This is the fun, geeky part of ultrasound. So you're going to want to use the linear transducer. If you look at the ophthalmology setup, right, they have a very specialized high resolution transducer for they call it the B scan, but for their ultrasound. And that transducer, they can do it in a number of different ways. And it's actually quite cool, where they'll apply it directly to the eyeball surface itself, or do like a little water bath. So they have kind of like this little inverted cup that they put in the patient's eye and fill it with water and then put it there. That's obviously not feasible for us because we don't have that transducer. And so when we do it in the ED, right, when we do it at the bedside, at the point of care, the best tool at our disposal is going to be a high resolution transducer, so a linear transducer. I suppose if you have a hockey stick, that could work as well. I've never tried it. It might be something worth trying because you can get that, narrow footprint, high resolution, but something that's going to give you that view, right? Because the nice thing about the eye, compared to all of those structures that we look at, save maybe skin and soft tissue, is that the thing is right up front, right? It's there visible to us. And so we don't have to worry about penetrating through layers and layers of, skin and muscle and soft tissue and various things like that. And so we don't need depth, right? The depth of the normal eye isn't that deep. And so we can sacrifice that penetration to gain resolution when we use the high frequency transducer. So grab the linear, right? The next thing you're going to want to do is use the ocular preset. So if you look up in the left upper corner there, I've circled it. This is really, really, really important. Number one, because it makes your life easy, right? The machine, the factory, and then us as, you know, in the division, we've set up these presets to really optimize the different functions on the machine for each individual modality. So for eyes, you know, we've set it up to optimize your gain and optimize your depth and optimize your focus, although I need to get rid of an extra focus point on this one. But it's really optimizing all those settings so that you can do as much plugging and playing as possible. You know, you can just put that probe down and not have to do a ton of tweaking to get all these settings just right. But the other really important reason to do ocular ultrasound is because it sets your power settings, right? So as we've all talked about, there's this ALARA principle, as low as reasonably achievable, you know, about wanting to use the minimum amount of energy in any form, right? When we're doing imaging, diagnostic imaging, the minimum amount of energy to be able to get the answer that we're looking at, right? And ultrasound is not immune from injecting energy into the body. I mean, without energy, we wouldn't have anything to assess, right? In this context, we're using sound energy. And so while it's safe, right, we do this on babies because, you know, it doesn't cause any perceivable physical harm, right? If we do this for a prolonged period of time, things can happen, right? And we talk about in the context of the thermal effects of ultrasound, as well as the mechanical or the cavitary effects of ultrasound. And so, you know, like all other structures, the eye is also sensitive to, you know, to energy, and probably a little bit more sensitive than things like a kidney or a gallbladder or your heart or lungs or things like that. And so we do need to try to honor and respect the ALARA principle and use as minimal energy as possible. So if you notice up on the top right that there's the MI and the TI, and they have very, very low settings. And if you use different presets, those MIs and TIs will be set differently. So this is the amount of mechanical energy and thermal energy that's being inserted into the patient to be able to reflect back the image. And honestly, with something really superficial like this, we don't need a ton of energy to penetrate deeply because we're not going to have really a ton of attenuation, you know, in the lid, you know, like we would have if you were scanning a gallbladder or something like that. So use the ocular preset. It's going to set you up nicely, and it's going to be the safest preset to use for your patient in this context, right? So next up is talking a little bit about gain, right? And this is one of the things about ocular ultrasound is what gain setting do you use? I've talked about this with some of our faculty. I've actually had some online, or actually not online, but it's published conversations in the literature about gain. And really the gain, remember, is this the volume of the returning sound waves, or maybe volume is the wrong word, but the intensity, or how sensitive your machine is to the returning sound waves. So if you think about it like a stereo, right? It's turning up that volume on the stereo. It doesn't change the quality of the music coming out of the stereo, it just turns up how loud it is. And so for the machine, it's kind of like that, where, you know, as you turn that up, you increase the sensitivity of the machine to these returning echoes. So it's brighter, right? It gives you a brighter image, but you at some point will start getting overgained and kind of overexpose your image if you turn up too high, and the same as if you turn too low. You can undergain or underexpose your image. So gain is really important, you know, because we need to, if it's too low, we may miss some subtle things. And if it's too high, we may blow out other things. So kind of a good rule of thumb is when you start your study, right, dial up that gain, dial it up to, you know, here we're at a gain of around 90, right? So I was originally taught, dial it up until you see kind of that, you know, the artifacts show up in the vitreous body, and then turn it down just a little bit. So you're seeing all the potential things in the vitreous, but not overblowing it, right? And when you dial it up, it'll give you a good view of what's in the vitreous. That being said, as you look then around the periphery at the wall of the globe, you may notice that's overgained, so you're going to have to dial that back down. And interestingly enough, each different part of the eye, so here's a little video running through kind of at that gain setting of 90, it gives you a great view of the vitreous, right? As you dial it back down, you're going to get a darker image like this, and you'll lose some of the detail and the clarity inside the vitreous. You know, and that's just kind of the way these different media work. And so when you think about it, depending on what you're looking at will affect kind of what level of gain you want to have set. So if you're looking at vitreous things, looking for a vitreous hemorrhage or something like that, you're going to need to turn that back up, turn that up. And if you're looking at the retinal, any retinal or choroidal issues, you know, they're going to be more intense in their signal return. And so you can tolerate a lower gain. And as we'll see in the vitreoretinal disorders, when you turn it, when you turn that gain, you may make these, you know, subtle detachments come and go, and that may help you differentiate between like a posterior vitreous detachment, which will, you know, resolve with will go away with low gain and will return with high gain, versus a retinal detachment, which may stay, you know, depending on the, you know, the gain setting you have. So, not to belabor that too much, just know if you're looking in the fluid, turn your gain up. If you're looking at the structures around it, you can turn your gain down to get a little bit better definition of kind of what's around there. So the other important thing that we need to, you know, assess and set is our depth, right? You know, I've always said to people, you don't need excessive far field. You know, once you find what you want and put it roughly in the middle of your screen. So at the beginning of this clip, you see it's too deep and you get a ton of the orbital contents, and at the end is probably a little shallow. So somewhere right here is reasonable, where you put your globe in the middle, right? You see a little bit of the optic nerve, you know, stemming out from the bottom, but really just maximizes your view of the wall of the globe and the kind of the contents of that vitreous body. So set your depth appropriately. That's step number 2. And then finally, you need to set your focus, right? So the focus in the ultrasound works very similar to the focus on a camera, right? If you're going to take a picture of the flowers in front of a mountain, right? You're going to need to twist that ring on the camera to be able to adjust that focus to the flowers and not to the mountain. And same here, if you set that focus, it's gonna direct the ultrasound beam that you're getting toward that depth, right? So the thing that's at that depth is going to be the crispest and most clear structure inside your image. So set your focus kind of where you want to look. So with that said, let's kind of turn our attention a little bit to patience and positioning, right? So we talked a little bit about the mechanics, the knobology, kind of how to set your machine up. Let's talk about then taking this machine to the bedside and actually doing it on patients. So the first thing is just position your patient appropriately, right? And by position your patient, make them in a place that's easy to get to, right? And comfortable for you. There's an interesting abstract that I saw presented a couple years ago about musculoskeletal complaints in ultrasound fellows, right? And the reality is, in the ED, we're the masters of making anything work, right? We can probably land a plane with a toothpick and some bubble gum in the ED, because that's just the way we roll. And so we tend to just kind of sacrifice our own comfort for the sake of just getting the image that we need. And so none of us are getting younger. We're all getting older. Things start hurting more. And so just set yourself up for success. Position the patient at a position that's comfortable for you, but also reasonable for them. And a reasonable position for the patient is probably in that partially sitting up, 45-degree angle, laying supine, in their bed, right? If they're sitting all the way up, it may be hard to kind of keep the jaw in the eye. If they're sitting all the way back, it may be hard for you to get to them. So kind of that 45-degree angle, is a good way to position your patient, right? And then when you do this study, the transducer can be placed in a number of different places. So if you're doing a full comprehensive B scan in the ophthalmology office with their specialized little transducer, they're actually going to be doing circumferential views directly on the sclera around the limbus, right? And they orient it in the horizontal and the vertical planes to kind of look at different parts of the eye. And then they also have the axial or just the mid-corneal view, right? You can do that in the sagittal or the transverse orientation. We don't have the small enough footprint really to be able to do everything the ophthalmologists do. And so if you look at a point-of-care typical study, it's going to be sagittally or transverse in the mid-axis of the eye, so over the cornea. That being said, the anterior portion of the eye, like the cornea, the lens, they can actually attenuate some sound. And so you may, if you're struggling to kind of see through that, you may have a little bit of extra success if you just slide right off the cornea and go just a little bit, if you're in transverse, just a little bit below the cornea, below the limbus. You may just get a little bit easier and more direct view into the vitreous body. But that being said, we're typically going to go over the cornea in the sagittal or upright orientation or the transverse or horizontal orientation, right? So here's an example of the sagittal orientation, basically putting a lot of gel in the orbit and then gently floating the transducer in that vertical orientation with the probe indicator towards the 12 o'clock position, or towards 12 o'clock position or the patient's head, right? From a ultrasound orientation standpoint, this is going to be the image that you get, right? So we can see up at the top of the screen here, we have their cornea, right, with the anterior chamber and that lens, that the lentiform or the lenticular form lens just beneath the iris. And so anything on top is anterior, anything deep is posterior, and then cephalad to our left towards the probe indicator, and caudad towards our right, or the anti-probe indicator orientation. Now, transverse gets a little bit more interesting, right? So the traditional teaching for anything point of care ultrasound is probe indicator goes towards the patient's right. So I did a little Twitter poll this week and threw that out there to I tagged some of my ultrasound colleagues in the region. And then obviously it got, some reach beyond that. How do point of care people orient their probe in the transverse orientation? And the most people do towards the patient's right, and about 4% of the people out there said they do it towards the patient's nose, whatever side you're on, which is, I think, interesting, because if you read the ophthalmology literature, their convention is you orient the probe indicator towards the patient's nose, so that when you look at the study, whatever's close to the probe indicator on the screen is going to be nasal, and then anything temporal would be farther from the probe indicator. So when you're looking, particularly in the transverse, when you're looking at the macula, that would always be to the right of the screen for us in the orientation that we do. Now, given the fact that there is pretty near unanimity in the point of care world that we always go towards the patient's right, I don't see a ton of utility right now in trying to disrupt that. So for now, the Metro standard, until we change it, is going to be in the transverse orientation, orient the probe indicator towards the patient's right, irregardless of what eye you're on. And then we'll just have to do the math and reverse engineer where the macula is in these transverse orientations. If I get a ton of blowback from the ophthalmologist, we can revisit that. But for now, that's what we're doing, just to minimize confusion, with probe indicators. So we know that the cardiac reversing is confusing enough, right? So here's an image of kind of how it's going to look in the transverse orientation. The probe is oriented horizontally with the indicator towards the patient's right, so that the right eye, the probe indicator will be oriented temporally. In the left eye, the probe indicator will be oriented nasally. So just know that that's going to be our convention here at MetroHealth in the emergency department. So when you look at the ultrasound image, right, we have, again, anterior, posterior, it's not going to change. You're still looking, that AP direction. But then things on the left side of the screen towards the probe indicator will be the patient's right. Things on the right side of the screen away from the probe indicator will be the patient's left, right? Now, how do you do this, right? Let's just walk through. I roll into the room. I set everything up. I introduce myself to the patient. The patient says, good to go. How do we do this? Number one, you got to have the patient close their eyelid, right? Now, the ophthalmologist will do a water bath, right? They have that special little lens that they put in to just fill up with water. We don't do that, right? We have just ultrasound gel, and I would recommend not putting the gel directly on the cornea. So have the patient close their eye, and so we can scan through the eyelid. You're not going to get a ton of attenuation through the eyelid, and so you'll get the images, just fine. Now, the big question that comes up is, do you use a tegaderm or not, right? And this is, definitely a point of debate out in the literature, and even, here at, in the department, right? Do you need a tegaderm? Do you not need a tegaderm? And I think the answer is, I guess you could do whatever you choose. There's no clear and hard guidelines that say you have to go one way or the other. The pro tegaderm side would basically say, hey, if I put this occlusive dressing over the eye, it prevents the patient from getting or opening their eye up accidentally. It would prevent gel from getting in their eye. Gel can cause just a minor amount of irritation, and so it may be more comfortable for the patient to do that. The counter to that would be, well, it's really hard to get a tegaderm on the eye and get all the air out from underneath the thing. There's always just a little bit of air in the medial and the lateral canthus, despite your best efforts. And so that air is going to cause a little bit of reverberation artifact and obscure some of the image that you're looking at. So it's harder to get as clean and crisp and clear of an image. And in the absence of significant harm, it's not 100% necessary. So, I think I'll let you guys kind of make up your mind as to kind of what you want to do in terms of tegaderm or no tegaderm. I tend to like the without, and just tell the patient to close their eyes and give them a warm washcloth at the end. Did that on myself the other day, and I can still see out of both eyes. But if you want to use a tegaderm, I certainly will not look askance at that as well. One technique that I read about that I haven't tried, which may actually provide some benefit, is taking like a petroleum jelly based product and just kind of putting a little bit in the medial and lateral canthus, maybe smear it on the eyelashes, and then put your tegaderm down, because that may be able to kind of fill up some of those voids before you kind of fill them up with air. So that may be an alternative to shoot the middle, but I've belabored that point, so we'll kind of move on. Irregardless, once you put the thing down or not put the thing down, you definitely want to use a copious amount of gel. This is not the time to skimp and save and to try to make budget for the year. What you're really wanting to do is fill that orbit up so that you can have a little standoff pad and glide your ultrasound transducer right over that pad to really minimize the amount of pressure that you put on the eye itself, right? Now, a normal intact globe, it won't be a problem if you put, a little bit of pressure on, but it may not be comfortable, right? But if you're scanning someone who's got the concern for a potential open globe, right? If they're a trauma patient, you don't know if their globe's open or not, then you definitely don't want to put extra pressure on. You really want to try to avoid that by making sure there's a big, nice, thick standoff pad that you can glide things over, right? Now, as you're scanning in either transverse or sagittal orientation, you're going to want to sweep through the entire eye, right? This is the benefit of ultrasound, is that we can kind of look in a very comprehensive manner throughout the entire eye, as well as what we'll see in just a minute, have them move their eye. So in sagittal orientation, you put it down, you find your landmarks, and you sweep from side to side the whole way. And then same thing in transverse, sweep up and down so you can view the whole limits of that eye, just like you would do, a bladder when you're checking a fast exam or a bladder volume. Just kind of scan that whole area that, of concern that you're interested in. Because what you may find is some of these pathologies may be kind of subtle. And so if you have a partial detachment or a small little detachment, out towards the ora serrata or somewhere in the periphery, if you just plop and play and then you're done, you may miss these small little, findings, that could blossom into something bigger later. So, and then finally, from a technique standpoint, have the patient move their eye around. The benefit of this over CT and over MRI is the fact that it's dynamic, right? This is why we do ultrasound for MSK things. You can actually move the joint, you can move the tendon, see what happens when you move it. And so when you have the patient, you find your image, you find your orientation, you find your landmarks, stuff like that, have them look up, have them look down, have them look left, have them look right. And all that's going to give you a thorough view of the back portion of the eye, so you're not missing anything. But it's also going to show you, it's going to tell you a lot when you have pathology to see kind of how mobile this pathology is. So for example, if you have echogenic material in the vitreous body and you have them move around, it kind of sloshes around like clothes in a washing machine, you're looking at probably a vitreous hemorrhage, right? If you're looking at, a rope-like structure and trying to decide, is it a retinal detachment or is it a vitreous detachment, the mobility of this thing may kind of point you towards one or the other. So have them move around, see how kinetic or static the different pathologies or structures are that you're looking at. So finally, let's wrap up this talk with a little bit of a discussion on anatomy, right? So as we move forward and looking at pathology, we can then kind of refer back in our mind to what normal anatomy should look like. And so just to remind ourselves about the eye anatomy in general, right? The eye is, a small circular fluid-filled structure that exists in the orbits, right? We all should have two of them unless something happens to one of them. And each of them, and there's different parts that, that are important to know and that we'll see. And so if you kind of think about it from an anterior to posterior perspective, or the line of travel of light that we're going to see, besides the lids and lashes, the first thing that the light is going to go through is, the conjunctiva, which is going to be a thin, clear membrane on the front surface of the eye that covers, the sclera, from the limbus out, and then kind of reverses back on itself to cover the inside of the eyelid. So you have your bulbar and your palpebral conjunctiva, right? But light's going to enter through the cornea, that thin dome-like anterior portion of the eye, right? Remember, a lot of the refraction of the light, a lot of the focusing is going to happen in the cornea itself. The lens just kind of tops it off and makes it sharp. But light's going to pass through there, right? Enter the anterior chamber, which is a fluid-filled chamber. So, look left to right. We have our cornea, our anterior chamber, and then it's going to pass through the iris, right? The aperture of the eye. If anyone's familiar with like an SLR camera concept, it's the aperture of the camera that increases or decreases the amount of light that gets in so that we can expose the image properly in our mind. And then light's going to travel through the lens and the lens capsule to get to the vitreous body. Now remember, the anterior chamber is filled with aqueous humor, right? That fluid in the anterior chamber, and it's produced behind the iris, travels through the iris into the anterior portion of the anterior chamber and absorbed in the canals of Schlemm, which is going to be kind of on that angle between the cornea and the iris on the inside, where basically where it's going to reabsorb that fluid, right? The vitreous body itself is kind of a gelatinous material. It's kind of deep to the lens, right? And it's going to have the internal limiting membrane, which kind of it separates the vitreous body itself from the retina. And it's not a cellular membrane. It's more of kind of like a glycoprotein type membrane. But it'll be, it separates the retina from the vitreous body, or that gelatinous vitreous body. And then the different layers of the posterior portion of the globe, starting superficially with the retina, right? It's the visual cells, right? The photosensitive cells. Deep to that would be the choroid, which is going to be the vascular layer. Right? Remember, the retina is an avascular layer, which is why a retinal detachment is such a bad thing. So you have your choroid, the vascular layer, and then obviously the thick outer shell of the sclera, right? Now remember, the retina kind of originates at the ora serrata, which is going to be up near, closer to the lens, kind of that ciliary body, and it's going to extend all the way, through the posterior surface of the globe and kind of be anchored in at the optic nerve, where all those neurons kind of travel out of the eye and into the brain, right? So the 2 points of anchoring, which will become really, really important for future weeks, is that ora serrata and then the optic nerve for that retina, right? Then obviously in the back part of the eye, the two key structures are the optic nerve, right? So we have all the central retinal artery and vein kind of emerge from the center of that nerve. And you have the neurons that kind of come out and spread out to form the retina. And then just lateral or temporal to that is going to be the macula, that really, the area with the very crisp central vision, the place where we have the sharp vision, or the fovea. There's a little depression there. And that's where all of our central vision is going to be. And obviously the retina is going to be the rest of the peripheral fields. So that macula is going to become very, very important when we talk about MAC on, MAC off type retinal detachments, right? So that's the gross anatomy view. If we turn that over to the ultrasound view, we can see these very same structures, maybe not in the same detail, but we certainly can see, the cornea, right? So that's that dome-like surface on the front part of the eye. And then deep to that, we have the anterior chamber, right? Filled with fluids, the aqueous humor. So we're expecting a fluid-filled chamber. If you have a hyphema or something like that, you may have some echogenic material in there, but generally it should be black anterior or anechoic. And then you have the iris, right? That membrane, or appears as a membrane between the anterior chamber and the lens in the eye. And then deep to that, we have the lens, right? And so the lens is also going to be typically anechoic unless you have a cataract. I posted a case up on Twitter yesterday of showing an example of a pacification in the lens, suggestive of a cataract. So there's the lens, and then deep to that, obviously, is going to be the vitreous body. So again, it should be pretty anechoic, right? You may see a little bit of ditzels, like really low level echoes in there. As you scan through, vitreous bodies, especially as we get older. But generally it's going to be anechoic. There shouldn't be a bunch of echogenic material in there. And then finally, we have the choroid retina scleral complex, right? So this wall of the globe, which itself, you can't distinguish, at least in a normal one, which is retina, which is choroid, which is sclera. It's all going to be just kind of one thick wall. Should be less than 2 millimeters or so in thickness, unless you have pathology, and then obviously you're going to have separation of those layers or thickening of those layers. So those are our basic structures, right? Obviously, we can add in the retroorbital fat. So if you want to look for like a retroorbital hematoma or something like that, that certainly would be where that would be. Not visualized in this image, but you can view, some of the extraocular muscles. And then finally, the optic nerve and its corresponding sheath is usually can be seen somewhere emanating from the posterior segment or posterior portion of the eye and then kind of extending deep into the screen. So that's a basic, view of the anatomy, both the gross anatomy and the sonographic anatomy.